We are live.
Then you can
Yes,
open the
sir.
talk, or Nikhil can open the talk.
Good evening, everyone. It's an honor and privilege to be here moderating this session among all stalwarts and seniors on the occasion of Guru Purnima. And we are going to discuss something very interesting. I think a lot of ophthalmologists, especially a lot of discussion on this particular molecule goes on in a lot of our WhatsApp groups. So we'll try to dissect everything related to the newest eye drop on the block, that is Pilocarpine, which has been formally introduced by Entod in the as the name of Presbyopia eye drop for treating presbyopia. So we have stalwarts and gurus like Keki Mehta sir, Lahane sir, who are going to be chairing this session, and we have a host of panelists. I request Dr. Nikhil Nasta sir, who will be co-moderating with me, to just introduce the chairpersons and the panelists, and then we can start off with the session.
Okay, thank you, Zen, and thank you, Entod. We are speaking today entire session on pilocarpine and presbyopia. We have a wonderful lineup of speakers and chairpersons today. Let me at the outset introduce, of course, Dr. Lahane sir. He needs no introduction. Dr. T.P. Lahane sir will be chairing the whole session. Welcome, sir. I also introduce our co-chairman for today, that is Dr. Keki Mehta sir. He's already here. Welcome, sir, and we hopefully will have a great session. All the questions will be answered. The panelists for today are Dr. Ragini Parikh ma'am, Dr. Vaishal Kenia sir, Dr. Jugal Shah sir, Dr. Arjun Ahuja sir, Anaga ma'am, and Chaya Shinde ma'am. I welcome everybody, and let's take it from there. Over to you, Keki sir.
We have a small correction. So Vaishal Kenia sir is also going to be our panelist for the session. And Dr. Jugal sir is not there, so just that one small correction. So Vaishal sir is also going to be the panelist.
I think we can begin with that, right?
Yes, yes. And since this is a BOA meeting, and we would like to open with Lahane sir and Keki Mehta sir to please give their words of wisdom on how we can open this meeting, and then we'll go on to the talks. Lahane sir and Keki sir, if you could just give a brief introduction, and then we can start.
Dr. Lahane,
Keki sir.
what is up, Pele?
Good evening, everyone.
Good evening, sir.
I welcome you all in the meeting, and which meeting is for this presbyopia, correction of the presbyopia by the low dose pilocarpine. Vaishal is doing very good work for these all meetings, and here the INTAR, I think we know that in the Western country it was used from 2023. So they use their 0.4% and also 1.25% of the pilocarpine for the presbyopia. But we are lucky in India. The INTAD, the only Indian company, introduced this pilocarpine, low dose pilocarpine for the presbyopic use. First of all, I congratulate the INTAD, everybody in the INTAD company. Because of them, I think we could get it. And this Masurkar sir, Nikhil Masurkar, and all the this
Sir, your network connection is slightly poor, I think. Sir is traveling.
ophthalmologists who help them. Request Keki sir to speak something. Okay. Well, I think I'm traveling, so now Keki sir can talk.
Yes, sir. Thank you so much, sir.
Thank you,
Over to you,
Keki
Keki,
sir.
sir.
Thank you, Dr. Lahane, for the introduction. I think, you see, presbyopia is one of the biggest problems which occur. And everyone at the age of 40 now suddenly faces a problem of reading, especially in the lower presbyopic group. The use of pilocarpine has over a period of time proven to be quite useful. It is good that Endot has made the solution here. We have to thank Mr. Surkar for that. And I think this is an excellent opportunity to share it. It is not without any problems, but at the end of today, you have an idea as to where it really works, where it doesn't. We had done a small trial of utilizing presbyopic drops a number of years ago, utilizing a slightly different combination, but with all of them, the same thing had arisen, that in the earlier stages, it seems to work well. Having said that, I will not tread on the path of speakers who are going to come after me, and give it back to our MC to now take over. Zain, you take over now.
Thank you so much, sir, for those words. And we'll now start with the talks, and we'll then have the panel discussion in between the talks. So to start off with, we have Dr. Suvira Jain, ma'am. Again, one of the great teachers of Bombay, teaching DNB residents and fellows since many years. Dr. Suvira, ma'am, so over to you for the first talk. So, ma'am is going to speak on understanding the unmet needs of presbyopia. Over to you, ma'am.
Thank you.
And can everybody else please mute themselves? There's some disturbance in the background. Dr. Suvira, you are also muted.
Yeah.
I know, I was just getting my slides ready. So let's understand the prevalence of presbyopia.
Sorry to interrupt, doctor. It's still not in PowerPoint show mode. Can you just stop for a minute and then reshare? Just select the entire screen when you go sharing. Just stop for a minute.
Okay, stop where? Go where now? It's showing on my screen.
Yeah, I've just stopped it. Once you click share, select the entire screen. Don't select the presentation. Just select the entire screen. When you go share, just click on the share button, left hand side top, entire screen, and then blue button share. Don't select the presentation, select the entire screen.
Okay.
And then the blue button share. That's it.
Well, okay. Does this work? Yeah?
Awesome.
Yes.
All good,
yes.
doctor.
Yes,
Right.
ma'am.
Sorry. So it's very interesting if we put it in this perspective that today, perhaps, the most common physiological change that happens in the human optical system in the aging eye is that of presbyopia. We know now that we all know without a fact that presbyopia is the age-related loss of accommodation of the lens, which results in our inability to focus for near. The problem with that is that as the age advances, therefore, we have suboptimal near vision and issues with that get more over a period of time. Now let's look at the prevalence of presbyopia. Multicentric studies have been conducted all over the world. They try to limit the various variables there, and here's what they found. The prevalence of presbyopia, along with the spectacle correction that was being offered to patients, was evaluated with a multicentric meta-analysis of all the clinical epidemiological evidence that people could collect worldwide. What they considered to be presbyopia by definition was the ability to read N6 or N8 using the Times New Roman font held at 40 centimeters or the preferred reading distance. What is important in evaluating the prevalence of presbyopia and the correction that is got to the number of patients, the most important clinical relevance of that is it's critical in evaluating, obviously, what is unmet globally in terms of presbyopia correction. This is what they found. Finally, what they realized in a study where they did a meta-analysis in the year 2015, they found that globally 1.8 billion people had presbyopia, which was roughly 25% of the population. Out of these 1.8 billion people, they found that 826 million, which is about 45% of these patients, were uncorrected for presbyopia for various reasons. Either they didn't find the need to get corrected or didn't have access to it. When multiple studies were analyzed at which were the patients that were likely to be uncorrected and what was the prevalence in terms of gender and other things, they found that presbyopia was slightly more prevalent in women as opposed to men, almost like a 46 and a 34% ratio worldwide. It was more prevalent in the higher economic strata of people, that is, people who were going to work, who had employments, who had access to to better healthcare systems, and it was less prevalent, and also the needs were less met clearly in the rural population where one did not necessarily go to work and one did not really require near reading glasses, or so they thought. The other thing they found is, what I'd like to discuss with you, is the changing trends of presbyopia over time. In the year 2000, when they did an analysis, they found that about 24% of people, that is a 1.4 million, suffered from presbyopia. The prevalence was 1.4 million. In 2015, as I told you, it went up to 1.8 million, which was like a 24%. And it is estimated to be on the rise. It is estimated roughly that in the year 2030, instead of 1.8, there'd be almost like a 27% incidence of presbyopia. From 1.8, they estimate the number of people showing up and with presbyopia would be almost 2.1 million. This increase in number is largely related to the increased lifespan, increased number of people reaching the presbyopia age and getting older. However, in the year 2050, when they looked at it, they realized that there is likely to be a slight drop in the presbyopia to about a 23%. That is, from 2.1 million, it's likely to go down to 190, and that reducing trend in 2050 is taking into account that over a period of time in the next few decades, we anticipate myopia to be on the rise. Another thing, these are complicated maps, but basically it shows you a region-wide distribution of presbyopia. And this clearly shows that people in the urban economic strata, those going to work, those with a good level of employment and access to healthcare, seem to have a higher prevalence of presbyopia. And as you go lower and lower down, those in the rural subset of people, those with less access to all of the same, not only have a less prevalence of presbyopia, there also is the place where the need for correction of presbyopia is certainly more unmet. In India, various studies were found, and overall the prevalence of presbyopia was found to be 43. It also corresponded with the level of the literary background of the place, the education of the place, the public awareness of the place, and all of those things. So presbyopia largely is going to have a negative impact, not only on the quality of life, as well as the national and the global economy, and particularly, I may say so, in the low and the middle income nations, such as India. So we come to this great need where all of us touching 40 and some of us much over 40 realize that the need for presbyopia correction cannot be underestimated. People have to get on. And so why is it really so important? In today's day and age, I mean, all of us on our tabs and more importantly on our cell phones, more on our laptops, the need to read cannot be, a small print on the phone cannot be underestimated. People, as they get older, also have a hobby of reading, wanting to get lost in their world of books. So their ability to read is very important. Not only that, many of them also need to write. People get on the literary phrase, they can even learn to write. Getting to all these specifics of improving lifestyles, it's also the normal things that people need to do. That is answering phones, answering text messages, booking their gas on the phone, signing checks, counting money, opening doors, women who need to knit, clean dal, and possibly cook. People need to look at their food. These are all very basic needs that people need to look at. In addition to this is also people who want to go to work, people in the in the urban sector of our countries who go to work, who need to have very good vision whilst doing their work for near and far and all of it altogether. People who need to journal, as all our children, my kids for sure, and many of us who have children who live overseas or not in the same house, as we get older, the ability to connect on FaceTime with our parents cannot either be, with our children, grandchildren, and all of them cannot be, not taken into consideration. And interpersonally building bonds, taking care of kids, grandkids, everything today is going to need us to actually be able to see for clear. All of this is going to have a huge impact, therefore, even on our quality of life. This is the overall prevalence of presbyopia, as studies have shown worldwide today. And therefore, in conclusion, I'd like to add that not only on a national level, but globally, understanding that it is such a public health problem, with almost 45%, 26% of the world population today having presbyopia, 45% of them not having their visual needs for near left unmet. It's so important to take all efforts to try and reduce, minimize, and perhaps eradicate the unmet needs of presbyopia, because we cannot underestimate the fact that uncorrected presbyopia affects our elderly population's ability to economic independence, their quality of life, and also the national and the global economy. Thank you.
Thank you, ma'am, for talking so well about what exactly the prevalence of presbyopia is. So before we go ahead to the next talk, I would just like to raise this question to the panelists. Where do you see how presbyopia is today, with having more digital devices coming in? Is the need for something for presbyopia more, or is it lesser than what it was before? Because first we didn't have any digital print. We had all newspaper print. And now with phones and digital devices, do you think that the need for a presbyopia correction has become lesser? So just a question to the panelists. Yes, ma'am. Anaga, ma'am. Yes, ma'am.
Yeah, actually, this is a very interesting question. And today, it's not just the unmet need, it's also how many people do not understand that they have presbyopia. A lot of people come to us with only headache, but they have never known that they actually need glasses in that age group. Secondly, they don't, they become very dependent on glasses. So one is the need, and secondly is a dependence. If they don't have their glasses, or if they're forgotten, or if they're broken, then their entire quality of work and their inability to continue with their work is very irritating. And thirdly, they don't know how to use the big glasses. Many of them come to us with a presbyopic glass, okay, bifocal, but when they are looking at the computer, they're looking straight, and they say that we have a lot of strain. They do not know that they need to actually raise their chin in order.
I would want to.
So there are so use these glasses. So all these problems can be reduced with a very good. Have to be, yeah.
I would just want
Dr.
to.
Yeah. Yes, ma'am.
Yeah, I just wanted to add something which is like pseudo presbyopia. This comes as very, very new to the presbyopic age. At 40, people start giving reading glasses, but sometimes it is underlying dryness which is creating a problem, or there is a convergence insufficiency which is creating a problem. So it's very, very important to identify that really it is presbyopia. That is very, very important. Some people are tobacco chewers, or some people have an occupational hazard like diamond sorters or jari workers. They have another kind of ciliary muscles fatigue, which contributes to early presbyopia. It's very, very important to identify really whether they are presbyopic or not.
So, Keki sir, do you have, since you see so many presbyopic patients, do you have any specific inputs about the unmet needs of presbyopia today?
Basically, presbyopia has increased rapidly over time. And the important thing to understand is also that a sickness, for example, or a hepatic disorder can lead to early onset of presbyopia. So these things do are there, and where as people are now getting more and more addicted to using a mobile, the requirement is now increasing. When the mobile was not that important, presbyopia, you could hold your hand a little further away and get away with it. Nowadays, the people are tending to have it more often. So more and more people are coming earlier, and I think that's a good thing.
Right, sir.
Also, because now people are dependent on a laptop, you can't function without it, and with a laptop, the requirements are naturally higher.
Right. Okay. Thank you, sir. So we'll move ahead to the next talk for the day. So we'll invite Dr. Akshata Oswal, ma'am, and she'll be talking to us about the clinical trial insights about this novel new drug that is evaluating the Indian pilocarpine eye drop. So over to you, madam. You can share your screen.
Yes, yes, yes.
Yeah.
First of all, I would like to thank. Am I audible?
Yes, ma'am.
Doctor, you're audible. And can you just make it in a slideshare mode, please? The full screen actually. Slideshow mode में नहीं है. Dr. Oswal?
Yeah.
Can you just make it in slideshow mode, please?
Yeah, one sec. Use slides.
On the top, there is slideshow, right? Above paragraph, there is a slideshow written on the menu.
One second. This is only coming when I am going to slideshow mode.
Can you just stop for a minute, doctor?
Yeah.
Yeah, just reshare. Stop your screen share, and ma'am, you can just reshare it with the whole screen.
Yeah. Just click on the share button once, and on the left hand side top there is entire screen. Select entire screen. Don't select your presentation. Just select entire screen. When you click on share button, left hand side top entire screen.
Entire screen. Okay.
Yes. Now click the blue button. Share ka. Awesome. Perfect. Thank you.
Yeah. Next. So
just click
of
on
all,
the screen.
I would like to thank all the chairpersons here, Dr. T.P. Lane, Dr. Keki Mehta, all the moderators and other speakers and panelists here for giving me an opportunity to be present in this webinar and talk about this clinical trial. So this trial is about evaluating the efficacies and safety of pilocarpine eye drop 1.25% for the treatment of presbyopia. Next. So this is an Indian phase 3 clinical trial on pilocarpine 1.25% conducted by NTOD for the treatment of presbyopia. So the objective of this study was the objective of this study was to compare the efficacy and safety of pilocarpine hydrochloride eye drop 1.25% versus placebo ophthalmic solution for the treatment of presbyopia. So this is a multicentric double-blind randomized control study
phase 3 clinical study, and the number of subjects in this study were 234, in which 117 were control, in which the placebo eye drops was put, and 117 in which 1.25% pilocarpine drops were put. So number of sites were 10, and the age group included in this study was 45 to 55 years, and the mean age was 49 years. 100% subjects have completed the study. That means there were no defaults in this, and the duration of treatment was 30 days. The dosage was once daily, and the eye drop was put in both the eyes. The conclusion in this eye drop was the efficacy. So the conclusion in this study was pilocarpine 1.25% has superior efficacy and good tolerability compared to placebo in the treatment of presbyopia. So the result was studied in 2 points. That is, one is primary endpoint and secondary endpoint. So this study, after 30 days on hour 3 in the mesopic light, it was studied that the proportion of participants have gained 3 or more lines in mesopic conditions, and the results were 29.6% participant gaining more than 3 line improvement. These studies are similar to Gemini studies, which were conducted in US, and that also showed a similar studies like this. Also, they found that the vision improvement was measured at different time points, say at 15 minutes, 30 minutes, 1 hour, hour 3, 6 and 8 hours on day 30. Significant improvement in gaining 3 or more lines in mesopic condition was seen with high contrast and binocular distant corrected near vision acuity has observed on day 30 at hour 3, hour 6 and hour 8. And the other endpoint was secondary endpoint, which was studied in photopic condition, where 65% subjects achieved 20/40 or a better vision in photopic condition on day 30 in hour 1 and 3. And for intermediate vision, there was also a significant improvement in photopic vision on day 30, hour 3. Similar results have seen in Gemini study also. Coming to the safety of this pilocarpine 1.25% eye drop, 82% subjects experienced no visual side effects. Like the common treatment related adverse events like eye pain was only 2.56%, irritation in the eye was 3.4%, ocular hyperemia, blurring of vision, pyrexia and headache. These were hardly anything. So there were no incidents of serious adverse effects including death. All the reported adverse events were mild in severity and no patient discontinued the clinical trial. So this Indian phase 3 study, the outcome was near vision improvement was statistically greater with pilocarpine and compared to placebo without compromising the distance vision. And pilocarpine has negligible visual side effects and good tolerability, offers new non-invasive spectacle-free treatment options for presbyopia. Thank you so much.
Thank you, ma'am, for that elaborate presentation. So, see, we have one more talk on, the studies part of it. So I think we'll invite the next speaker to talk on the studies, and then we can have a discussion with the panelists about their experience as well. Okay. So I invite Dr. Manish Sharma, sir, to speak on real-world experience with the Gemini 1, 2, and Virgo clinical trial. Then we can have a discussion on this. Manish, sir,
thank you so much. Thank you so much, Zain. All right. Am I visible full screen?
Yes, sir, you are.
All right. So at the outset, I would like to wish happy Guru Purnima to all the teachers out here, to my teachers and to all the other teachers here. I think Akshata has made my job very easy. She's spoken about the Indian trial. I would be speaking about clinical trials that were conducted in the US. So the first one is the Gemini 1 study, where again the objective was to evaluate the efficacy and safety of pilocarpine in individuals with presbyopia. A significantly large participant group of 323 in the 40 to 55 age group. Now, this treatment had just a once daily dosage, which was conducted over 30 days. And it concluded that pilocarpine 1.25% was superior over the vehicle in the mesopic distance corrected near visual acuity on day 30 at 3 and 6 hours with an acceptable safety profile. The primary endpoint was a gain of 3 or more lines in mesopic vision at 3 hours on day 30, and the result showed that 30.7% participants gained more than 3 lines. And the key secondary endpoints, well, it was measured at different times, like the Indian study at 15 minutes, 30 minutes, 1 hour, 3 hours, 6 hours, 8 hours, and 10 hours, and in different conditions of lighting, mesopic, photopic, with both near and intermediate vision being tested. And the results show that there is a significant vision improvement at every time point as compared to the vehicle. Vis-a-vis the safety, the common adverse effects noted included headache, visual impairment, hyperemia, and eye irritation, but all were classified in the mild category and no treatment was needed. And more importantly, no participants discontinued the treatment due to the adverse effects. Now, the Gemini 1 and 2 clinical study, in this, the object was to actually test the efficacy in individuals with or without history of laser vision correction, that LASIK or PRK. This was again the 40 to 55-year age group. And this treatment concluded that the Pilo treatment effectively and similarly improved the distance-corrected near vision acuity in presbyopes with or without history of laser vision correction. The efficacy endpoints was a proportion of participants gaining 3 or more line improvement on day 30. The results compared the Pilo and the PRK group to the vehicle, as well as the Pilo LASIK PRK group to the Pilo non-LASIK PRK group. And the results were measured in different lighting conditions. The efficacy results showed that the mesopic distance-corrected near visual acuity, well, 35.1% LASIK PRK participants gained more than 3 lines. And this is similar improvement seen in both the LASIK PRK and the non-LASIK PRK groups. The photopic vision also, 40.5% of the LASIK PRK participants gained more than 3 lines. So once in this, the participants gaining more than 3 line improvement was higher in the LASIK PRK participants as compared to the non-LASIK group. I would like the panelists to comment on this later. And in the intermediate category, again, the LASIK PRK participants gained significant improvement in the photopic conditions, and similar improvement was seen in both the LASIK and the non-LASIK groups. So the outcomes of Gemini 1 and 2, the study effectively improves, it shows that the treatment improves near and intermediate vision without compromising distant vision in individuals with presbyopia, regardless of whether they have undergone previous LASIK or PRK. And this may allow continued independence from spectacles for these patients. Now, there was another study, that is the Virgo study, which is a twice daily. So the first 2 studies were basically once daily. And in this, the Virgo study, patients were administered the medication twice, 6 hours apart. The design settings and participants were 230 subjects in the same 45 to 55-year age group, and treatment over 14 days. The conclusion here was that near vision improvements were statistically greater with pilocarpine twice daily than with the vehicle, without compromising on the distance acuity. And the safety profile of Pilo twice daily was consistent, and systemic accumulation was minimal, supporting the twice daily administration. The primary endpoint here was mesopic distance-corrected near visual acuity measured on day 14 at 1 hour, 3 hours, 6, 7, and 9 hours. And 36.8% participants gained 3 lines or more of the mesopic distance-corrected near visual acuity. The key secondary endpoints were gaining more than 3 lines mesopic, photopic, more than 2 lines mesopic, and a gain of more than 20/40. So patient-reported outcomes, well, greater improvement in vision-related reading ability with pilocarpine and greater reduction in the use of presbyopia-related coping behaviors was also noted. Change in pupillary size, well, the reduction in pupillary size observed over time in the pilocarpine 1.25% twice daily group mirrored the visual acuity outcomes from 0 to 9 hours. So it suggests a mechanism of action primarily based on pupillary constriction. Thank you.
Thank you, Manish sir. So now we have all the studies from India and the Gemini Virgo studies also. So now we open the discussion with the panelists. So panelists, I would like to know from you, do you all have any practical experience with pilocarpine for presbyopia? And if so, please enlighten us on its exact usage, the doses, and how it works. So we'll start with Ahuja sir and Chaya Shinde ma'am. Do you all have any experience with the pilocarpine eye drop?
Hello, Khatib.
Yes, sir.
Yeah, I have tried this in few patients, but
Yes, sir.
it usually helps up to 1.5 plus diopter presbyopic correction. If patient has got above 2 diopters, then it doesn't help much.
Okay.
And the word of caution, before starting pilocarpine, one should screen the retinal status. There should not be any retinal changes because they are prone for retinal detachment. So this should be considered in the cases when you prescribe this pilocarpine. And especially those who wear contact lenses, no, so I advise them to remove the contact lens, put pilocarpine, and after 10-15 minutes, they should reinsert the contact lens. They should not put directly over the contact lens.
Okay.
Yeah.
So, sir, you mean less than 50 years of age group, it
Yeah.
works, and
Yeah,
more
it
than
works.
50?
Yeah,
it
not
does
above
not.
50, not above 50.
Okay.
And one more additional advantage which has not been discussed, it can also be used in EDOF lenses where they have got distance and intermediate when near they struggle. So EDOF lens also for pseudophakic patients we can use.
Yeah.
So then near they are happy.
Okay, we'll come to pseudophakic discussion a little later.
Okay.
But first from panelists, Vaishal sir and Anaga ma'am, your experience with using pilocarpine for presbyopia?
Then I think even Chaya Shinde ma'am
Yeah.
wants to say.
Yeah, ma'am, please.
Yeah, ma'am, go ahead.
No, I have not used, but as Dr. Sir said, I agree that first retinal examination screening has to be done, as it is said in the literature that it may lead to retinal detachment. So I agree with sir. Otherwise, we have not used.
Yeah. Okay. So I would like to share my personal experience where I have put the Presview eye drops in my own eye. So I put this around 4 or 5 days back when the medical rep came. So I put it in my eye. It acted almost within 15 minutes, and the peak action I got an improvement around 2 lines. And the most important thing then which I got was a dull headache. It's very, very irritating, that dull headache which you get, the persistent, which in these studies they had described around 10 to 15% patients. And early presbyopic patients will come with a headache, because they are straining their ciliary body. And I am not sure how much that dull headache would be detrimental for them to continue. That's one. The second thing which I felt was the irritation, dryness in the eyes. We all are having some borderline dryness, and to which we add. The third thing which I feel is, today we have a concentration of 1.25%, and one size does not fit all. We may have to, just now only 1.25% is available, but we may have to dilute it to 0.75% pilocarpine concentration, because in all these cases, it's the ciliary muscle which is spasm, which is creating a problem on the retina or the headache. And here the main action of pilocarpine, what we are using is on the pupil, not on the ciliary body. So we can combine it off-label pilocarpine with brimonidine, which is available just now as 0.2%. So this could be one of the ways of titrating and giving it to patients, as I feel that low presbyopes, 45 years plus 250, we may use a lower dose of pilocarpine, and to sustain the action, we may add brimonidine to it.
Okay.
Yeah.
It's a good point.
Another thing is, apart from retinal examination, we also need to rule out other problems like cataract, for example, because that will even further reduce the clarity of vision, number one. Number two, if there's any history of uveitis, because that will probably increase the intraocular, and any presence of intraocular inflammation. This should not be used. So when not to use also is important. Plus, if there has been a patient who had recurrent iridocyclitis in the past, some posterior synechia, obviously the pupillary constriction pupil is not regular. So these patients we should not use. If patient is doing regular night driving, like if the pupil is constricted, then their peripheral field of vision at night also will be reduced. So
Correct.
these are the patients. So you need to take a proper history. So it's not just the retina, but also the history as to what the patient wants exactly. And he needs to understand that this is not a one-time solution. He has to keep putting it and what will be the long-term effect. So these patients, over a period of time, whether they will develop any kind of changes and they need to keep coming back for monitoring other things like retina, even if they didn't have a problem.
The
Eye
other thing,
pressure, if patient is on any other drops. So all these points also need to be remembered. Yeah.
the other thing is customization. You can put it in one eye, this thing, and work it as like a monovision, this thing, so that can reduce the headache part. The second thing which I was thinking, the pupillary size, the corneal spherical aberration, because we can customize the treatment according to each individual, the dose, everything.
Yeah. One more observation, if you all have seen, is the number of patients who gained, percentage of patients who gained 3 or more lines is around 29-30%.
Correct.
So which
3 out of 10.
means, what about the rest of the 70?
Yeah.
What about the rest of the 70%? Okay, what happens to them? That means their primary endpoint was gain of 3 or more lines. That means the rest of the patients may have had 1 or 2 lines. Now the question is, maybe in like Ahuja sir very rightly said, in early presbyopes, 1 or 2 lines improvement also may help. So probably because we have a very large range of patients, 40 to 55 years, maybe that is why their endpoint of more than 3 lines is maybe what they have kept. But 30% probably was a little less. That's what I thought. Yeah.
True, ma'am. Just to ask Vaishal sir again, since you had used it on your own eye, how bad is the headache for the patient as a to use the drop in as repeat value? So would you want to use it on a daily basis? Considering that you feel you may have headache or you will get used to that kind of headache.
See, Zen, this is a very subjective feeling. I may, because of if I'm motivated, I may persist using it, but I felt demotivated about it, to be honest. That a dull ache was this thing, and I was not able to focus on my work that particular day while looking into screening the patients. And all of a sudden, after putting the drops, I forgot about it. And when I got a headache, then I recollected that I put these drops. That's why I'm having a headache. So that's the other thing. And the in this study, what percentage of patients have to be broken down into age group? 40 to 45, they have more accommodation reserve than 45 to 50 or 50 to 55. So that has to be sub-analyzed and seen what the result would be and titrate. And as Anaga said, it has to be customized. You cannot have one drop for all the age groups and different types. Even residual error. You have a residual astigmatism. It will contribute to you helping. So we'll have to customize things.
Yeah, I myself have also used this drop. Past 1 week I'm using, and I did not have any headache other than just mild irritation. So maybe it's in early 40s, this is more helpful than, after 45.
So also, like Vaishal mentioned, that it's reported about 15%. So not everybody is going to get the headache. That is also there.
So Manish, I had used it, and my other friends in my age group also. We have a gang. We all used it. We didn't find much benefit with it.
Okay.
We didn't feel any difference as such. And I am in the range of 150, 175.
Another thing that I was thinking about is, if patients use it for a long time, vis-a-vis the dilatation and the cataract later on we do, what kind of problems do we envisage? Because, the pupil is going to, if you're going to have sustained constriction of the constrictor pupillae only, I'm sure we are going to have issues with the iris. What is the panel's take on that?
Yeah.
Yeah.
Long-term effects, any comments on long-term effects of the drop in terms of uveitis or anything?
Yeah, we will face problem.
We'll have to wait and watch, I think, sir.
Maybe long-term studies required, not just 30 days.
The other studies which have been done, like the Brio 1 and Brio 2 study, they had combination of carbachol with brimonidine. So the Brio 1 and Brio 2, they've concentrated on having a sustained action, almost 8 to 10 hours of action with 0.75% pilocarpine with brimonidine. Another study, carbachol with brimonidine. So carbachol is another agent which can be used, which is slightly long acting than pilocarpine.
Okay. What is the main mechanism of action? Is it only pupillary constriction or
Pupil,
even
pupil.
accommodation
Yes, it
is playing a role?
Okay, thank you.
So the question arises, does it work in pseudophakics also? It should have the same effect in pseudophakics if it is working only on pupillary action. So is it the same for pseudophakic patients?
Can I take this question and answer?
Yes, sir.
See, it all depends on what kind of EDOF are you using. If you're using a spherical aberration dependent EDOF, you're cutting off the spherical aberration, and that would also hinder. That is point one. Second, the lucidus like which have a near element, or the eye hands which has got a near element right in the center. If you constrict the pupil, your distant vision will get affected much more. And these patients will complain about the drop in the vision because of your contrast sensitivity. So more than the gain, the quality of vision will get affected by using these drops.
So monofocal IOL, only monofocal IOL for reading?
No, pure monofocal.
Pure monofocal.
You can, because see, a 2 millimeter pupil gives around 2 diopters of accommodation, and the spherical aberration gives around 0.5 diopters to 0.75 diopters of an aberration. See, I'm 54, I'm still not using any presbyopic glasses because my pupil is slightly on a smaller side and I've got a spherical aberration too. So I'm distant emetropic in both the eyes. So this is a personal example where at 54, I'm still not using near glasses at all. My vision is N8 just now without glasses, and I can function very well. So where to use and where not to use a presbyopic correcting eye drop would be a customized solution.
Thank you, sir. I would like to ask Keki sir and Lane sir as well. Do you all have any experience with presbyopia eye drops for Presview?
Well, no personal experience because I had long since crossed into the dye and theme number edition. But we have been using pilocarpine for many years. It is comparatively a very safe drop. In the earlier days, that is all that we had for glaucoma, and used it over a series of years. And frankly, I have never seen a retina detachment occurring thanks to pilocarpine. So I think the incidence is probably so low it's not even worth considering. But yes, it is true. In between, I managed to get some of these drops. We tried it on a few patients. In the low myopic category, the low presbyopic category, yes, it does work. But the important thing is to note, if the person has got a big pupil, it normally doesn't work. If the pupil is small, it seems to work.
Okay.
So I think that is just about the simplest way. You check with the torch. If the pupil is, some people have large chronic pupils. I don't think it's going to work on them. The small ones, yes, it works because it works on a pinhole effect. I don't think it works on anything else.
Okay. Lane sir, do you have any personal experience with Presview?
Well, I have not a personal experience of this medicine, but I have used in the 6 patient up till now. The drops were given by Intor, and out of that, I think those the 5 patients they came back to me. Other patients they have not come to me, but out of that 5 patients, 2 are happy. And if you ask me why these 2 are happy, because there is 40, 42 like that. But another 3 patients are of the 50, 55 like that. They are not much happy. So I think in the such cases where the age is less, that is definitely useful, but not for this. And secondly, I think we are not up till now we have discussed about the complications. But if you consider these 5 patients, it means in 40% of the patient they are happy when in the young 40s, early 50s you can say, and above 50s it is not much useful, these drugs. Thank you.
Okay, sir. Thank you, sir. So We move on to the last talk of the day, and that is by none other than Vavikar sir. So we've spoken a lot about pilocarpine eye drops. Vavikar sir is going to tell us what beyond pilocarpine for treating presbyopia. Over to you, sir.
Can you see my screen?
Yes, sir, it's visible.
Great. Thank you very much, BOA. Happy Guru Purnima to all the gurus. So after discussing pilocarpine eye drops, I'm going to talk about surgical options which are available for presbyopia management. Whatever the option is, the most important thing is proper patient workup and counseling to ensure a smooth flow. Because as we all know that patients' expectations are very sky high, and it is sometimes very difficult to match if the result goes slightly astray. Basically, there are four techniques by which we can do. Number one is lens-based surgery. That means the crystalline lens-based surgery where we put a trifocal or a multifocal IOL or even a EDOF IOL. Second thing is blended vision with LASIK. And third thing is corneal inlays. And the fourth thing is that presbyopic ICL. Now, corneal inlays and presbyopic ICL, these are basically theoretical topics. Neither have got much experience and they are not in vogue. So let us concentrate on trifocal EDOF IOLs and then on blended vision by LASIK. Now, as we know that presbyopia is definitely a problem for a lot of patients. And therefore, people are looking for solution, especially after the COVID pandemic. There has been a shift in the patient thinking, and patients are willing to pay more for surgery, and therefore there is a sudden surge in the use of these lenses. However, if we do not take proper precautions, then we are in for a surprise, and that can be sometimes become really nasty. So it is very important that we understand the eye and we understand the patient's psyche also before we go ahead. As compared to previous trifocals and multifocals, today's lenses, they are much better in the sense of giving glares and halos. And we also understood the technology better, and therefore the results are better and patient acceptance, doctor acceptance is better. So to start with, we always look for dry eye. Dry eye has become a menace, and we all know that. And without treating dry eye properly for 15 days or 1 month, we should not go ahead with any kind of surgery, whether it is a crystalline lens-based surgery or with LASIK. Similarly, epithelial mapping has become...
Sorry to interrupt, Vavikar sir. Your screen is not going ahead actually.
Yeah, like this. It's
We,
going yeah.
We are on current solutions for presbyopia. You're on that screen only.
Oh, I'm sorry. Okay. So I'm talking about lens-based surgery now.
Okay.
So epithelial mapping has become very, very important because patients who have got subtle dry eyes, they do have epithelial irregularities. These induce refractive errors, higher order aberrations, and we can be in for shock. Unless we treat them, we are not going to get a good result. And then we start from beginning of the eye, anterior to the posterior, the angle alpha, endothelium, and then we look for the pupil size. We are all discussing about the pupil size. See, any trifocal IOL, if the pupil is less than 2.1, it acts like a monofocal IOL, and that is where the pilocarpine starts. And therefore, this has become two separate sets for patients. So if we put a trifocal and expect pilocarpine to work, it's not going to work. However, a patient with a monofocal and in one eye left behind, we are left behind, say minus 1.5 or minus 1, you put pilocarpine in that eye, that may work like a magic and patient will be glass free. Then macula OCT, everything becomes very, very important. More and above that, doing a perfect surgery is very, very essential. The CCC cover on the IOL has to be uniform and all sides. Okay. We have to look for diseases which cause decrease in contrast sensitivity, and there are different professions for which these lenses do not work. Like Vaishal was giving example. In addition to that, pathologists, especially those who are using only single eye microscope, nowadays it is getting rare, they seem to be not adjusting very well. And then individual variation in adaptation and tolerance. Brain plasticity plays a very, very important role, whether you're thinking of cataract surgery or monovision laser vision correction. Now, in monovision laser correction, there are two types. Number one is the Presbyopia. I do not have much experience in Presbyopia, so I will not talk about it. The second, the most commonly performed by me, is advanced monovision. That means in the dominant eye, we leave behind one plano for distance, and in the non-dominant eye, let's say left eye, we leave behind around -2. Along with that, we shift the Q value in dominant eye to slightly minus, whereas in the non-dominant eye, we shift it to -0.6. Now, what happens? The non-dominant eye, which is left with -2, can see clearly till the distance of 50 centimeters. 1/2. We know that from dioptrics, we come to focal length. And the dominant eye sees from infinity till around 0.5 meters. And the Q value, there is increase in the depth of focus, and therefore there is a blended vision. Because of this, patient does not have to use any glasses. This works very well. Up till now, there has only one patient in whom advanced monovision has not worked, and that was a patient who had road traffic accident, and he was in coma for 3 weeks, and he had lost all his brain plasticity. Now, to choose between them, refractive error plays a very good role. If it is a plus number, patient is a hypermetropic, then presbyopic lens exchange works wonders. Whereas if it is a myope patient, then blended monovision by either presbyopic or advanced monovision works wonder. Then we go on to the corneal inlays. There are multiple types, but this becomes more of a theoretical discussion. There are so many difficulties. There are complications of cornea, fibrosis, haze, infection. While doing cataract surgery later on, it becomes a big problem, and therefore this is not in vogue. Similarly, presbyopic ICL, the problem is that we cannot change the ICL every now and then. Okay, so if you at the age of 45, you put a lens with an add of -1.5, it will become inadequate at the age of 55, and therefore it is still not in vogue. Now, last and not the least is we are talking about EDOF. EDOF is also a very good option, because what has happened is most of these patients, they do not require N6 vision. They require N6 vision very sparingly, and with both eyes together, they can manage little bit of N6 vision, but EDOF, they give excellent intermediate vision and functional near vision. And people who are night drivers, who are worried about halos around the light at night, for them EDOF works better. So especially if it is a young patient, say 45, even 50 age, if we put a EDOF, patient becomes 6/6 and binocularly N6, and it becomes a really good option. I think that's all for today. Thank you.
Thank you so much, sir, for summarizing all the surgical techniques we have. So, any final comments from the panelists? Chaya ma'am, you're on mute.
Yeah.
Yeah.
I think longer duration studies are needed on it to know the effects like headache, as Vaishal said, and how long the headache lasts and how much it is irritating, how it affects your capacity to function normally. That is also important point we have to see. So longer duration studies are needed, and maybe in more patients, all age groups, above 50 also. As other panelists have said, that below 50 it works somewhat. So above 50 it doesn't work much. So we need to find out that also. Many patients studies needed. That's what I feel. Sample set should be more.
So I think take home points can be that as of now, less than 50 years, it should be working, and more than 50, it's questionable. I think that is take-home message that we can give the audience from the discussions that we have had. Anyone else would like to say anything, or we can close the meeting for today?
I'd just like to add.
Yeah, what? Oh,
sorry, go ahead.
Yes.
Go ahead.
Keki sir. Sir.
Yes, sir. Please.
No, sir, please. Yeah.
No, sorry, I just wanted to add on something. We had done quite a bit of work on pilocarpine eye drops long before. One thing we had noticed is if you want to increase the effect of pilocarpine, you put in a drop of NSAID with it. And it increases the effect almost to 3 to 4 hours. It is not mentioned anywhere here. This is the work which has been done. But the question always has been as to whether the unwarranted use of NSAID drops, is it really useful or not? But it does increase the effect of pilocarpine for a period of time. The other thing is, with these drops, are really functional only in the lower age, in the lower presbyopic group, and in those in whom, where really presbyopia is starting. But you will need to refill it after a period of 4 hours. So that is what the experience we had from the ones we had used long ago. But the headache, the problem was that after some time, the headache tended to come on, and even in those patients where it had not started earlier, after they used it for a period of 3 to 4 months. So, and a lot of people then dropped out of the trials which we had done purely for that reason. And since the trial wasn't really systematic, we dropped it. But that is what the initial experience was. This is what it was 6 years ago, actually speaking.
Okay, sir.
But I'm sure, for those who are just at the point where you forget your reading glasses, you put a drop of pilocarpine, it works fine. For 3 hours, the effect is good. After that, it tapers off. And the refilling it, you can refill once. Second time, it doesn't work so well.
Right, sir.
Right. There is an option of using an NSAID which does tend to increase the effect.
That's an interesting observation,
Yeah,
sir.
one more thing. Yeah, what I feel is finally, these are all one-off experiences we have all had. I think we need to use these drops more with our patients, have our own set of experiences with patients after a good counseling. And these are very good solutions. See, there will be no magic drop available. Any kind of medicine will have some kind of limitation, some kind of side effect, but we should also look at the positive side of it, that we were not looking at this as a solution for presbyopia in all these years. Now that we have one, we can make good use of it in the proper subset of patients with a proper counseling and in the right way. So I think awareness for our patients as to which patients will benefit in what way and what the patients need to expect out of it will definitely help. So somewhere, if it is going to help some patient, definitely I think that is the success of all these new innovations. Obviously, we cannot consider it to be a magic wand for everyone, but with good patient selection and with more and more usage of these drops, I think our experience also will take us to better, newer horizons.
I fully agree.
Absolutely.
What we need is a much larger analysis over a larger period of time.
Exactly.
I mean, we're just starting to use the drops. Maybe if we did the same seminar after, say, 4 months, we get a far better information to how well they can work. But offhand, for those who are starting, I think it's a great idea to use them. I think a lot of people will benefit from it. It won't work for the higher ones, but the lower ones, I see no reason why we can't use it. And pilocarpine has been very safe. We used it for a very long period of time.
It's on.
Thank you, sir.
Sir, what I wanted to add is choosing the right patient is a very important point. But even, I had a headache. So in a retrospective, I was thinking, why not dilute the concentration to 0.75% and seeing, or mixing it with brimonidine and checking it. Because we don't want that ciliary spasm to occur and causing a headache, or that spasm to cause, a problem on the retina. So both the problems are sorted if we can mellow the.
No, I don't want anything. I'm done now.
Yes, Bhavika sir has something to say.
Vaishal, we have used pilocarpine in the past, and we know with 1%, 2% also, patient gets headache for 1 or 2 days. After that, it disappears. even in the Gemini study, I would have liked to understand that 11% was in the first 5 days or they had headache throughout. And if we use it probably for a longer time, the headache may disappear.
The other problem is what a chronic pilocarpine used with such a high concentration may cause iris cyst, and the sphincter may go into a spasm, and the pupil will become miotic. So while operating later or fundus examination can be a problem. So it's always better to titrate the concentration to a lower one. You can have different concentrations, just like previously we had pilocarpine at 0.5%, 1%, 2%.
Similarly, I just add to your point. Similarly, now we do not know what are the chances of malignant glaucoma with this 1.25% pilocarpine.
But definitely, sir, pupil morphology will change, sir, if you're chronically instilling pilocarpine. This is what we know since ages, sir.
Yes.
So thank you all. Very interesting discussion.
Khatib, two things I would like to say.
Yes.
It's like a magic. Along with these drops, you tell them to have an extra table lamp, like extra light, which causes more miosis, and they feel much better. And second is you tell them to do conversion exercise every day. So that also helps. So these two things, if you add, they are very happy.
Very good point, sir.
Yes, sir.
Okay.
So thank you all. I think we have come to the end of the meeting. And big thank you to Entod for putting this meeting together. It was very much required. I would like to start by thanking our esteemed chairpersons, Dr. Keki Mehta sir and Dr. Lahane sir, for sparing time out and guiding us on the use of pilocarpine for presbyopia. I would like to thank our panelists for the meeting, Dr. Anaga ma'am, Dr. Arjun Ahuja sir, Dr. Chaya Shinde ma'am, Dr. Vaishal Kenia sir, and I would like to thank our speakers, Dr. Bhavikar sir, Dr. Suvira Jain ma'am, Dr. Akshata ma'am, and Dr. Manish Sharma sir. Hope I've not missed anyone. Thank you, Entod, for putting the meeting together. Dr. Reshma, Secretary of BOA, is here. Would you like to add in something for the closing remarks?
Before Reshma, I think Zen, we need to thank you and Nikhil for moderating the session. Thank you so much, guys.
And thank you, Nikhil sir, as well. Sir.
I was just going to
Thank you, thank you. In fact, Zen did the whole thing, so I didn't have to do anything. Thanks, Zen.
And pranams to all the seniors here on Guru Purnima.
Yes. No, it's a very important topic, and it's something that is the need of the hour because, as I said, there are many patients who come to us. They deny. There's a big denial about them that they want to wear glasses and that they've crossed 40 and that that glasses are the next thing that they will get. But if these drops work, it's going to be extremely nice, and I think that whole section of patients between 40 to 50 will be really helpful for them. So thank you for this talk, and I think as everybody said that a lot needs to be still spoken about, and a lot of more evaluation needs to be done about these drops. So hopefully we have more details next time when we do this.